Right, we'll get started.
Yes.
Thanks for joining us. This is, believe it or not, our 6th webinar, and it's been a great experience, and I hope you all find it helpful. So we'll start again by reminding you, everyone, about our mission to be the most educated community about atrial fibrillation in the nation. I really think it's very doable, and if any of you review the last 6 webinars, including this one, I guarantee you, you'll be the most educated, even without additional webinars. So we'll start by reviewing the first 5 webinars in case anyone joining us for the first time, so they can go back and figure out which topic they may be interested in within atrial fibrillation to review. In the first webinar, we talked about the multidisciplinary team members we have. This is a very good team. You get the chance to meet Dr. Verma and to meet Dr. Hernandez, and you'll have the opportunity to meet the rest of the members with different topics in the future. More recently, we had 6 cardiologists join us from West Florida Hospital. 2 of them are electrophysiologists. During the first webinar, we discussed the difference between sinus rhythm and atrial fibrillation, and how atrial fibrillation is simply an electrical disorder that results in loss of effective mechanical function of the top chambers of the heart, and how that is the reason why we have increased risk of stroke by forming a clot in the top chamber that can break off and cause a stroke. And we discussed different modalities of reducing the risk of stroke in patients with atrial fibrillation. In webinar 2, we discussed the different antiarrhythmic medications, and we learned the different types of atrial fibrillation: paroxysmal, persistent, and permanent atrial fibrillation. And we also discussed and learned about external electrical, direct current cardioversion, and we ended with this slide showing that catheter ablation is more effective than antiarrhythmic medications maintaining sinus rhythm. And the third webinar, we went into further details about catheter ablation and the basis for ablation lesions being that the left atrium, especially within and around the openings of the vessels that bring the blood from the lungs to the left top chambers, are the source of most of the triggers for atrial fibrillation, and that's the basis for targeting those areas in the left top chamber. So there will be no ablation for atrial fibrillation without going in the left top chamber to create the lesions. And we discussed the different lesions could be only 2 simple circles, additional lines, or different targets depending whether the atrial fibrillation is paroxysmal or persistent. And we also pointed out that ablation lesions could be performed by using radiofrequency energy, or heating the tissue, or by using cryoballoon or freezing the tissue. And then we reviewed different studies that showed consistently atrial fibrillation ablation is more effective in maintaining sinus rhythm and improving the quality of life compared to antiarrhythmic medications. The fourth webinar was given by Dr. Verma, who talked in details about the safety, the risk, and the complications associated with catheter ablation for atrial fibrillation. And last month, Dr. Hernandez talked to us in further details about the risk of stroke and how to prevent it in patients with atrial fibrillation. Now today, we're going to be talking about the role of pacing and other cardiac implantable devices in atrial fibrillation patients. So the learning objectives of today's webinar is, number 1, we're going to learn about what pacemakers are and what other implantable cardiac devices there are. At least we give a brief summary of those devices so we are familiar with them. Then we'll talk about when pacing would be indicated in patients with atrial fibrillation. I get a lot of questions asking me when somebody has atrial fibrillation, do I need a pacemaker? When would a pacemaker be indicated? So I thought that's a common enough question to address. Then we'll talk about the difference between single and dual chamber pacemakers and the value of those pacemakers to diagnose and to treat different arrhythmia. Once again, just to remind everyone that atrial fibrillation here on the right is basically electrical circuits going all over the place in the top chambers of the heart, driving the bottom chambers of the heart, the ventricles, very fast and causing the pulse to go fast and give us the sensation of fluttering within the chest sometimes. Compare that to sinus rhythm, where you have the electrical signal exclusively generated by a spot in the right top chamber. That spot is called the sinus node, and the electrical signal with every beat goes down to the bottom chambers through this electrical connection that we call the AV node. So keep those two in mind as we are discussing atrial fibrillation and the role of pacing. The two structures you need to keep in mind whenever we talk about the need for pacemakers are the sinus node, which is the natural pacemaker our heart has basically when we are born, and now each one of us, hopefully none of us is in atrial fibrillation, each one of us is having the heart beating in what we call sinus rhythm. That means this spot in the right top chamber is the spot that's making electricity. And that signal goes down to the bottom chambers through this electrical wire or cable, if you will, we call the AV node. So this is the electrical generator, and this is the electrical wiring system that distribute that electrical signal to the bottom chambers, so the bottom chambers can pump the blood to the lungs, the brain, and the rest of the body, and that's what gives us the pulse when we check for our radial pulse or pulse in general. So in general, when we tell people you need a pacemaker, that means either the electrical wiring not working, or the electrical generator is not working. So if you have no spot that's generating electricity, or that electrical generator or natural pacemaker is very slow, that's when we need a pacemaker. Or we may have perfect electrical pulse generation, but the wires that conduct that impulse from the top to the bottom are not working. So these are the two main reasons why someone would need a pacemaker. No electricity generated fast enough, or the wires are not conducting the impulse from the top to the bottom chambers. And that highlights again the sinus node and the AV node. Now this is an animation basically and representation of pacemaker in place here. This is the ribs, basically the heart within the chest. We took out the lungs, and you can see the electrical pacemaker. This is what we call the battery or the generator, connecting two wires that they go through the vein in the chest, and the vein would lead us to the bigger vein that lead us to the heart. So we put one wire in the bottom chamber of the heart and one wire in the top chamber of the heart. That's what we call dual chamber pacemaker. That means you have two wires going to two chambers of the heart. The wires in the pacemakers, or what we call pacing leads, they go on the right side of the heart, because that's the side that pumps the blood to the lungs. You don't want any of the wires to go to the left side of the heart that pumps the blood to the brain, because those wires may have a clot form on top of them, and you don't want that clot to go to the brain. If there is a little clot, it can go to the lungs and be filtered because it's usually very small. So something to keep in mind, we go with the wires in the vein and we go to the right side of the heart. The electricity is generated in this area. We call it pulse generator, what we call also the battery. When we change somebody's battery, we change this whole thing. And these are the wires. The battery usually lasts up to 10 plus years. The wires can last 30 plus years. And this is how we implant it. Local anesthesia, we put a sheath in the vein. Through that sheath, we put the wire, one in the ventricle, one in the atrium or the bottom chamber. And the way we fix that lead is actually a screw. This is the proximal end, or the lead outside the body. When we put it in, we actually screw it. There is a little screw that comes out of the tip and screw inside the muscle. And that's how the lead is fixated and get in contact with the heart muscle so that electrical signal can get to the heart muscle and stimulate the muscle. So this is another animation of the pacemaker implantation. Now, another device you may heard of is called Implantable Cardioverter Defibrillator, or ICD. You can see the picture here is similar to the pacemaker. You have a pulse generator, or ICD generator. You have wires that go inside the heart, one in the top, one in the bottom. So it's dual chamber ICD. The difference between the pacemaker and the ICD, the main difference is that defibrillator is a perfect pacemaker, but it can also not only prevent the heart from going too slow, in case the heart goes really fast, like now the heart is beating and then all of a sudden goes really fast, you can probably see that. It can shock, it can deliver the shock that get the heart back in rhythm within seconds. So a pacemaker is not a defibrillator, but a defibrillator is a pacemaker. And a defibrillator will be a perfect pacemaker if needed, but also it will save the patient's life if the heart goes really fast in a life-threatening way. So now this is a brief overview of a pacemaker and a defibrillator. Just to educate you even more about it, this is a chest X-ray on the left of a patient with a dual chamber pacemaker. We learned about dual chamber, meaning two wires, one in the top chamber, one in the bottom chamber. You can see this is the heart for those who have not looked at the chest X-ray before. This is the heart in the middle. The gray-black area here, these are the lungs, one on the left, one on the right, on both sides of the heart. And you can see the tube here. This is the airway, what we call the trachea, basically, that through which the air comes to the lungs. So you can see the airways, the lungs on both sides, and the heart in the middle. And this is the collarbone on this side and the collarbone on the other side. The same thing on the right of the slide. The one on the left is a pacemaker. The one on the right is a defibrillator. Now you're going to be an expert reading chest X-rays as well. You can see the size of the defibrillator is a little bit bigger than that of the pacemaker. And you can see the wire or the lead for the defibrillator has this white line here and another white line here. Both are what we call coils. These are the coils through which this device delivers the shock. And you can see the heart lies between this coil, and the device. And the shock is delivered between this device and these two coils. And the heart is basically in the field of that shock. And that's how that shock gets the heart back in rhythm, should the heart goes into a life-threatening rhythm very fast, something like 200, 300 beats a minute. So on the chest X-ray, you can see the wires, the defibrillator wires have coils on them, and the defibrillator generator is bigger. Let's dig deeper. If you open that ICD generator and open the pacemaker generator, you can see another difference. See, this is the pacemaker. You can see this part, this is the battery. All these circuitries here, these are basically the brain of the pacemaker. When you cover them, it looks like this. So when we say we're going to change the pacemaker generator, it doesn't mean we're going to open this up, take the battery and put another battery in. It simply means we take the whole thing out and replace it. So keep that in mind. Compare this pacemaker generator to the defibrillator. The defibrillator has bigger battery and also has additional part, and that's the capacitor. You need to have a capacitor, a place to store that shock so it could be delivered right away when needed. So this is why the defibrillator generator is bigger than that of the pacemaker. So now we know about the pacemakers and defibrillators. Let's talk about the implantable loop recorders. We talked about this the very first webinar. And this is the size of this implantable defibrillator relative to the clip here. And this is the site of implant, usually in the left anterior chest. under the skin. And for those who had one of these, it's done under local anesthesia. The incision we make is about 10-millimeter incision, and you don't have sedation. You drive yourself in and out, and we can also do it sometimes in the office. We're getting ready to do it in the office. This monitor has the ability to monitor continuously every heartbeat and keep a record of any time the heart goes too slow or too fast or irregular going into fibrillation, up to 3 years. And anytime it records anything significant, it can transmit that through a transmitter next to the bed, just like the one for your defibrillator or pacemaker. And we'll receive that, and you'll get a call from us if there is anything significant. So these are basically the 3 main devices that we implant for heart rhythm purposes. A pacemaker to prevent your heart from slowing down, a defibrillator, that's a perfect pacemaker, plus treating any life-threatening fast rhythm that the patient may have, and then a diagnostic tool, the implantable loop recorder I just showed you, that can monitor your heart rhythm up to 3 years. Now let's go back to our atrial fibrillation and compare that to pacemaker on a 12-lead EKG. If you remember from the very first webinar, normal rhythm, you have top chambers contracting, giving this deflection on the ECG here. The bottom chambers, because they are bigger, thicker muscle, they give bigger electrical activity. So top, bottom, top chamber, bottom chamber, top chamber, bottom chamber. And we just learned that the top chamber is driven by the sinus node. So every beat in the top is followed by a beat in the bottom. When you go atrial fibrillation, you can see this squiggly line here, very fast, going 300-400 beats a minute. That's the top chambers fibrillating, going all over the place. And the bottom chambers following fast and irregular. So this is atrial fibrillation, this is sinus. When we go from atrial fibrillation, this is another example of atrial fibrillation. Again, focus with me. The larger deflections are the bottom chambers beating, and that's what gives you the pulse. The top chamber deflections, these are little low amplitude, wavy deflections. This is atrial fibrillation. If you go to the bottom strip, you go to sinus. See this sinus? Top chambers, top, bottom, one-to-one. Here, you're still going into fibrillation. As you convert from atrial fibrillation to sinus, you did not miss many beats here. There is no long pause here. And a lot of people don't feel a difference as they go between atrial fibrillation to sinus. As you recall also from the first webinar, atrial fibrillation could be very symptomatic or could be without symptoms at all. But I just want to highlight here that as we convert from atrial fibrillation to sinus, it could be seamless without the heart stopping for a long pause that could be causing some symptoms. Compare that to this ECG. This is one of my patients. This is the heart going fast, and this is atrial fibrillation or flutter going really fast, about 150 beats a minute. Then I don't think any of you see any heartbeat here, do you? This is about 6 or 7 seconds here. 7 seconds, no heartbeat. Then luckily there's a beat. Then about 3 seconds, no beat. Then another beat. Other 4 or 5 seconds, 4 or 5 seconds. So every 4 or 5 seconds you have one beat, and then finally the heart beats again at relatively normal rate. How long does it take for a normal person in a standing position to pass out? Maybe about 4 to 5 seconds. Definitely within 7 seconds you're out. And that's why somebody with atrial fibrillation, the heart could be going really fast. Then when it stops and goes back to normal, the heart takes a while to recover. Remember that sinus node we discussed? The top chamber of the heart? The normal heartbeat goes about what? 60 to 100 beats a minute? 50 to 100 beats a minute? When that fibrillation is happening, we agreed that the top chambers are fluttering and going at 300 to 100 beats a minute. So what does the normal sinus node say? You know, it says, my God, this heart is going 300 to 400 beats a minute. I'm only going 60 to 100. My service is not needed. Let me fall asleep. Well, it goes to sleep. When atrial fibrillation decides to stop, it takes a while for that sinus node to wake up. We call it recovery time. All of a sudden, it's required to work. And when it's not young, when it's been hit too long and suppressed too long by the atrial fibrillation, it can take 7, 10 seconds sometimes to wake up. And that pause can be a problem. And since atrial fibrillation is unpredictable, you cannot predict when this is going to happen. You could be driving. We don't like that. You could be sitting, you pass out, that's fine. You could be lying down, you pass out. There's no fall there. But if you're driving, if you're standing, if you're on the ladder, it could be a problem. So this is what we call conversion pause. You convert from atrial fibrillation to normal, and this is the pause. We call it conversion pause. So keep that in mind as we are discussing pacemaker indication. Of course, the first thing that comes to your mind, oh my God, the heart should not slow down this much. Anytime you think the heart cannot be this slow, think pacemaker, because that's your only way to prevent the heart from slowing down when you have no other reason for the heart to be slow. Sometimes medications you are taking can cause your heart to be too slow. You can stop the medications and things improve. But when we have no reason to correct, then a pacemaker is the answer. So that's what we call a conversion pause. This is another more recent one. You can see it in color. We have a nicer telemetry strips. And you can appreciate this wavy line here. This is the fibrillation going on in the top chambers, bottom chambers following, not very fast, but still following about 70 to 100 beats a minute. And then the fibrillation goes away and the rhythm comes back, sinus, normal, and then you go and no beat, then this beat, and there's no beat for about 6 seconds, then another beat comes in. Once again, the pause did not happen right away, it happens within a few more seconds. Regardless whether it's happened immediately or 5 or 10 seconds later, your heart's still not beating for 6 to 8 seconds or 10 seconds. And guess what happens? Passing out spell, or what we call syncope, or close to passing out, what we call near syncope, just in case you see those terms when you Google something. So this is another example of conversion pause. This is another example of a pause, but it's not a conversion pause. So let's review. We know by now all these towers here are the bottom chamber signals. High signal, the bottom chambers beating fast. This speed here is about 150 beats a minute. Slower, slower. Look at this beat, and there is no beat between this beat and this beat. That means there's no pulse. And here we have about 6, 7 seconds. Did the rhythm convert from atrial fibrillation or flutter to sinus? No. Look, the patient is still in fibrillation. Somebody is calling, I'm sorry. The patient is still in fibrillation and flutter, which we'll learn the difference between fibrillation and flutter in a future lecture. Still in fibrillation and flutter, but the response in the bottom chambers is very slow. Look in the same patient, going too fast, 150 beats a minute, and then no beat for about 7, 8 seconds. How are we going to fix this very fast without worsening the very slow? Once again, anytime you have too long of a pause, anytime you have too slow of a heartbeat, what do you think of? Pacemaker. Does the pacemaker fix the fibrillation? No. Does it prevent the fibrillation from happening again? Not really. It only prevents the heart from being too slow and improve the symptoms that are associated with the heart being slow. And those symptoms could be simply fatigue or dizziness or passing out spells. Another example of slow heart rate. In this case, Look at the bottom strip here. This is a beat, heartbeat, heartbeat. You can see them very regular, evenly spaced. And the speed here is about 30 beats a minute. This is an EKG of a patient who's been on medications to help keep him in rhythm. And those medications kept the patient in rhythm. However, it caused the heart to go very slow. So now the patient, instead of feeling bad with fibrillation, he's feeling bad with very slow heart rate, and heart rate ranging between 30 to 40 beats a minute. No pause. This is not life-threatening, but this is quality of life-threatening. This is another reason to put a pacemaker. So the pacemaker will prevent the slow heart rate, improve the symptoms, and the medication in this case will hopefully keep the rhythm normal or stay away from atrial fibrillation. But we also learned every rhythm medication eventually will fail. Nonetheless, we highlighted all these possibilities where a pacemaker could be indicated. Now let's look at this. Now I think you can recognize when those bottom chambers beating very fast, those spikes or those high electrical signals are very close to each other. You know that's very fast. Do you know how fast this is? This is about 180 to 200 beats a minute. That's really fast. Sometimes we have patients, no matter what we do, we cannot get them out of atrial fibrillation. And we learned that's what we call permanent atrial fibrillation. Well, okay, we decided to live with atrial fibrillation. But the problem is the atrial fibrillation is going on in the top chambers, and this AV node is conducting very fast, and the heart rate is really fast. Then we say, okay, let's give medicine to slow that AV node or this connection here. So we give medications, and the same medications that slow the heart rate down, unfortunately, can drop the pressure. So we could be sometimes limited. We just cannot give any more medications. So we are stuck with a position where the top chambers cannot go back in rhythm. The bottom chambers are very fast. The patient is very tired, and no medicine we can give can slow it down. So what are we left with? Really, the main option is left with is to ablate this AV node. So the top chambers can go 300 or 400 beats a minute, but have no communication to the bottom chambers to cause it to go fast. Well, you say, okay, how is the heart going to go? Well, it's not going to go unless you put a pacemaker in. So that's a situation where you would put a pacemaker in first in the right bottom chamber and ablate the AV node. So the bottom chambers will only be driven by the pacemaker and not by the top chamber driving them very fast. And that will make the patient feel really, really well and much better. So let's summarize. Atrial fibrillation and pacemakers, yes, there's a role for pacing. When? If you have too fast and too slow of a heart rate alternating, whether you're converting from atrial fibrillation to sinus rhythm and there's a big pause, or whether going slow and fast during the same atrial fibrillation. Or if you give medications to help somebody stay in rhythm, but unfortunately those medications cause the heart to go into a very slow, what we call marked slow or sinus bradycardia. Or if we decide to ablate the AV node, then we have to put a pacemaker to keep the heart going. So these are the main situations where pacemakers are indicated in people with atrial fibrillation. Keep in mind, pacemakers prevent the heart from slowing down, does not stop it from going fast, but we'll learn about their role regarding their diagnostic values. Now, our next objective is to learn the difference between single chamber and dual chamber pacemakers. Well, I think by now you got it. The one on the left, you have only one lead going to the bottom chamber. The one on the right, you have two leads going, one to the top, one to the bottom. So the one on the right, we call it dual chamber pacemaker. The one on the left, single chamber pacemaker. One would we use dual chamber pacemaker, one would we use single chamber pacemaker. So single chamber pacemaker could be in the top chamber or the bottom chamber, but for the purpose of this talk, this single chamber going to the bottom chamber, this dual chamber going to the top and the bottom. To have dual chamber, that means this pacemaker can pace the top chamber and can pace the bottom chamber. But if you have somebody who is in fibrillation all the time, meaning the top chamber is going 300 to 400 beats a minute, there is no point in putting a wire in the top chamber to drive it what? Faster than 300? No. So if your top chambers live all the time in fibrillation, there is no point in putting a wire in the top chambers. So that's why somebody would have single chamber versus dual chamber. And if you remember, we talked about paroxysmal atrial fibrillation, where the heart goes in and out of atrial fibrillation by itself. Persistent atrial fibrillation, when we have to shock the heart to get it back in rhythm, or do ablation, or give medications. Permanent atrial fibrillation, the heart is in atrial fibrillation all the time. So, as long as we have some time in sinus rhythm, whether paroxysmal or persistent, we need dual chamber pacemaker if pacemaker is indicated, so the top chambers could be paced. When you live always in fibrillation, there is no point in having a dual chamber pacemaker. A single chamber pacemaker to the bottom chamber is enough, because the top chambers are going very fast and the pacemaker does not go faster than atrial fibrillation, and no point in having a wire in the top chamber. So when it comes to single chamber pacemaker, this is an example of the pacemaker generator I've shown you some pictures of, and this is the wire that goes in the vein to the bottom chamber, and this is the screw. Look at the little screw there. That's what we screw in the heart muscle itself. Compare that pacemaker, single chamber, to this single chamber pacemaker. Yeah, it is. This is exactly the relative size. And this is a good representation of how small this pacemaker is. And you say, wow, this is a pacemaker. Where's the lead? Where's the battery? Where's the circuitry? The battery and the circuitry is inside this little capsule. And those tines, what hold the pacemaker to the heart muscle, like this. So because the pacemaker is in direct contact with the heart muscle, you don't need a lead to come down from the pacemaker generator here to inside the heart. Everything is one capsule. This is beautiful. This is only a few years old, and we've been using it, but so far we only have single chamber pacemakers, what we call leadless pacemaker, meaning a pacemaker without the need to have a lead. Advantages, many. Number one, when we don't go through the vein, we're not going to create vein problem, because as the vein has the wires inside it, sometimes it can create a scar and it can occlude that vein. Number two, when you have a lead or a wire going through that valve, it can affect the valve function. Number three, when you have hardware with that wire in place and you get infection in the blood, it has a higher chance for that infection to stick on the wire, and then we have to take the whole thing out. All those problems are avoided with this pacemaker. How do we do it? This is actually one of the last few I've done, so I took a picture of it. It's delivered through a sheath. This is the heart beating. As this pacemaker comes out of the sheath, those tines I showed you goes inside the muscle and get hooked up there. And this is what it looks like inside the heart under X-ray. And you can see the back part here, this is the battery, and the front part, this is the circuitry. Can you believe that? And they can last 7+ years. God knows what tomorrow have for us. But this is the latest in single chamber pacemaker. Now, we learned about the devices, the different devices. We learned about the difference between dual and single chamber pacemaker, and the latest in the leadless single chamber pacemaker. Let's talk about the diagnostic values of those devices. We talked about the implantable loop recorder, watching your heart rate and rhythm and stuff like that. But how about the pacemakers and the defibrillators when it comes to atrial fibrillation? Those pacemakers, as I mentioned, their main job is to pace the heart, to prevent the heart from going too slow. But also, they are watching everything. And anytime the heart goes fast, they will keep a record of it, including going fast in the ventricle or in the atrium. We learned that atrial fibrillation is a problem in the top chambers. So let's talk about atrial fibrillation diagnostic value. Look at this screen. This is a piece of the printout I got on one of the patients. This is in 2011. And you can see here, it says hours per day. It goes from 0 to 24. That's 24 hours per day. On the x-axis, you have January, February, March, April, May, June, July. So this is a 6 months interval. And every line represents an atrial fibrillation episode. It tells you when it happened and how long. Like this episode here lasted about 8 hours. This episode here lasted 24 hours. This episode lasted 24 hours for about 5-6 days. And those episodes are happening off and on. So is this paroxysmal, persistent, or permanent atrial fibrillation? This is what you call paroxysmal because the episodes are happening and terminating by themselves. So the patient may not feel much. When we check this pacemaker, it tells us that the patient has been having atrial fibrillation. Why that's important? Because we learned the earlier you intervene for atrial fibrillation, let's say with ablation, if the patient is symptomatic, the higher the success rate. Number two, we learned that atrial fibrillation is one of the main causes of strokes. And some patients don't know they have atrial fibrillation. So if we can discover atrial fibrillation as early as possible, and the CHA2DS2-VASc score or the risk of that patient of having a stroke is high, we can start them early on anticoagulation. And that's one of the value. But this is a representation how that pacemaker is showing us the paroxysmal episodes of atrial fibrillation in this patient over a 6 months period. Also, I would like to highlight, look at the natural history of atrial fibrillation. It starts with 2 little episodes, fewer increased frequency of episodes, longer duration. Then look at that. Longer duration and more frequent. So with time, in this case, over 4 or 6 months, you go from paroxysmal to almost persistent. Another example. Another patient, 2010, 2011. This is only 2 months. Well, no, actually, June 2010 to August 2011. That's more than a year. Once again, the pacemaker prints out this. This is 24 hours of the day. This is the date, July, August, September, November. This is 2 months interval, but each one is a month. You can see here, 2-3 episodes happened few hours each in June, July, and August. Then late August, the patient went right away into atrial fibrillation, stayed in it for 24 hours every day since, right? There's no area where there's no atrial fibrillation. So this was a very fast progression from paroxysmal atrial fibrillation to persistent atrial fibrillation. And we did not do anything about it between here and here. But this is just an example that atrial fibrillation is so different among patients. One you can see having paroxysmal, like I just showed you, for 6 months, and one you see jumping from paroxysmal to persistent right away. And here, if you look at this here, patient's activity, hours per day, and you say, how do you know that? Well, we don't tell you how much that pacemaker is recording, so you don't get scared. No, I'm just kidding. So this is basically tells us how active you are, and we rely on that to, watch how active the patient is. And the pacemaker record that based on accelerometer and sensor in the device itself. If you're walking around, you stimulate that sensor more often if you're just sitting in the same spot. So a lot of information we can get out of that pacemaker. Another example. This is, now we know it, 24 hours a day, gives us the duration per day, the x-axis, the date. You can tell this patient was here for more than a week, almost 2 months. That's persistent atrial fibrillation. We did cardioversion here, actually, got them back in rhythm, had a few episodes, went back into persistent atrial fibrillation in April. Then we did ablation here in May. And between May of 2010 and January and May of 2011, nothing happened. That's a perfect, successful ablation procedure. So I was so proud of it. That's why I kept it. And this is how it's helpful. Pacemaker gives us a lot of diagnostic information that help us figure out what's going on. Another example of ablation, this patient started with persistent atrial fibrillation. They are 24 hours a day, February, April, and then we gave them medicine to help get them back in rhythm. Did not keep them in rhythm long enough, you know, in and out still. It changed persistent to paroxysmal. We did the ablation here, and you can see good results with no significant recurrence of atrial fibrillation. This is an example of a permanent atrial fibrillation of a patient who had atrial fibrillation that has been asymptomatic, older patient, and we decided to just live with it for different reasons. And this is basically 24 hours a day, all the time in atrial fibrillation. And if you look at the patient's activity, not much at all. That was a patient who basically was not doing well, and the quality of life was not related to the atrial fibrillation. So this is to highlight the diagnostic value of having a device implanted. And the pacemaker will tell us a lot of information, and actually it has been very helpful. Some of you may have a pacemaker or may know this. A lot of our patients, we discover that they have atrial fibrillation without having any symptoms through following their devices. And that gives us the advantage of knowing about this, giving them the anticoagulation that may be indicated to reduce the risk of stroke and other embolic events. I said the pacemaker does not stop atrial fibrillation from happening. The main purpose is to stop or prevent the heart from going too slow. And it keeps a record of any time the heart goes fast, and you saw how accurate that record is, which day, how long, and over what period of time. But it can also do one thing, and that is stop the top chamber when it goes fast by pacing that top chamber faster. So let's look here. This is the recording from the top wire in the top chamber. This is the recording from the bottom chamber of the pacemaker. You can tell the top chamber is going faster than the bottom chamber. This is going 170, 180, 190 beats a minute. The pacemaker here paced the top chamber faster than it was going, and then let go, and that allowed the top chamber to go back in rhythm. So sometimes the top chamber wire or pacemaker lead, when it senses the heart going fast, it can pace it faster, get hold of that circuit that's going fast, then stop, and hopefully the rhythm will go back to normal. That's not always the case, but sometimes the pacemaker helps stop fast heart rhythm when it starts. Now, we'll highlight the different kind of strokes. Strokes could be either because of bleed inside the head or because of a clot or stopping the blood flow in one of the branches of the blood vessels that take the blood and the oxygen to the brain. So if we look at the strokes, more than 70%, in this case 71%, estimated to be ischemic, meaning due to a clot or blockage in the artery, not due to hemorrhage or bleed. So most of the stroke, more than 2/3 of the strokes, are as a result of blood flow stopping, not going to the brain. Out of the 70% of the ischemic strokes, almost 1/3, what we call a cryptogenic stroke, meaning the patient will come to the hospital with a stroke. We do a CT scan of the head. We don't find any bleed, so it's not hemorrhagic stroke, that's ischemic stroke. Then we check for the reason for that narrowing or blockage in the artery that caused the stroke. We check the heart, it looks fine. We check the big artery, the aorta, make sure there's no plaque in it, nothing, no clot in it, it's fine. We look at the neck arteries, it's fine. We check for everything we know to check for, and we can't find a reason for it. That's what we call cryptogenic stroke. Cryptogenic stroke is basically a stroke that we could not identify a reason for it, and it's usually ischemic stroke. So it's a diagnosis of exclusion. We check for everything we know of. If we can't find a reason, we say, okay, that's what we call cryptogenic. Cryptogenic stroke, it doesn't mean there's no reason for it. We just have not identified that reason. It has been shown that atrial fibrillation, as we discussed many times, is one of the main causes of strokes. And also, atrial fibrillation could be asymptomatic. So is it possible that cryptogenic strokes are caused by asymptomatic atrial fibrillation that comes and goes, and by the time the patient was in the hospital, that patient was in normal rhythm, so we couldn't figure it out? Because of that possibility, we've been monitoring patients with cryptogenic stroke with providing them 1-day monitor, 7-day monitor, or 30-day monitor. The longer you monitor, it makes sense, the more likely you're going to find something. If you monitor for only 1 day, you're going to miss 90% of atrial fibrillation if the patient has it. If you monitor for 7 days or 1 week, you miss up to 80%. If you monitor for the whole month, you can still miss up to 60% of atrial fibrillation episodes. So you need a longer monitoring time to check for any atrial fibrillation, or what we call subclinical, meaning asymptomatic. And that's where that implantable loop recorder we discussed, the one the size of which was the size of the clip, comes to play. Remember that monitor, it can live up to 3 years. So on the x-axis here, you have 36 months. On the y-axis, the percentage of patients who had atrial fibrillation detected. This study, Crystal AF, randomized more than 400 patients to receive implantable loop recorder or to just being monitored the usual way. And they found out that if you receive an implantable loop recorder, within 3 years, up to 30% of those patients will have atrial fibrillation, versus only up to 3% in the control group atrial fibrillation would have been documented. So almost 10-fold better ability to detect. And that's why the guidelines have changed when it comes to patients with atrial fibrillation or patients with cryptogenic stroke. Stroke, that's ischemic, meaning not because of bleeding, and we could not identify the reason for it. We need to consider the possibility of having atrial fibrillation. Older guidelines in 2014 suggested we can monitor the patients up to 30 days. But because of that study, in 2016, the recommendations changed. If you monitor for 30 days and you cannot find atrial fibrillation, it's okay to go ahead with long-term implantable loop recorder could be considered to document silent or subclinical atrial fibrillation. Now, we have a pacemaker, we have a defibrillator, we have an implantable loop recorder, and no stroke yet. And then we detect atrial fibrillation. Remember, that pacemaker shows me if it is seconds, minutes, or hours, and actually tells me exactly how long. How long does atrial fibrillation have to be there before we say this is significant? The answer to that simply, we don't know. We know that if you have atrial fibrillation for 20 hours, 10 hours, 3 days, more than 10 hours, there's a lot of agreement. It's significant enough to require anticoagulation. But we don't know what to do with the minutes and seconds and few hours of atrial fibrillation. And we have no data to say this is definitely high risk and you should deal with it as if the patient has higher burden of atrial fibrillation. To answer that question, we have these 3 studies trying to randomize patients who have atrial fibrillation detected, short duration of atrial fibrillation, we're talking about minutes and few hours, and randomize them to receive a blood thinner like Eliquis in this case, apixaban, and we have this study, actually we are part of this study, or receive normal care and see if that makes a difference. If those studies show that no matter how short the episodes of atrial fibrillation are, the risk of stroke is relatively high and you need to consider blood thinner, then we'll change our practice. I think with that, I'll finish this talk and we'll open the lecture for questions.